Welcome everyone for this workshop on mental illness, emotions and healing. I hope you are wide awake because it's an important subject. There is a passion about helping people in emotional suffering and to see what can be done through their work, through the grace of God. Before we start, we would like to introduce the speakers. So it's my pleasure to introduce Cesar. Maybe you can stand up. Cesar has done a long way to join us. He's from Brazil. He has a long time experience as a psychiatrist. I would guess, 25 years, 30? 30 years of experience as a psychiatrist. And he's worked in Brazil, in a regular clinic, outpatient clinic. He's worked for hospitals, Adventist hospitals in Brazil, and also in the States. She has worked for lifestyle centers in Brazil, in the States also, at Wildwood Sanitarium. Okay, I have to take this out. They don't want to see my name. Okay, it's better? Okay. So Cesar has a lot of experience in a Christian psychiatric approach, in natural treatment, lifestyle treatment. For myself, I have an experience of only 15 years as a psychiatrist. Before, I was doing internal medicine for 10 to 15 years. And then I turned on the wrong side, going as a psychiatrist. And I tried to combine both specialties in my work, and I think they balance well in my head. I work in Switzerland, near Geneva, Clinique La Linière. It's a hospital of 95 beds. And among those beds, there are 15 beds for psychiatry. And we work also for outpatient treatment. Now we would like to know better about you. So you're not going to present yourself name by name, but I believe that there are at least 3 groups of people here. People who are here who are interested in health, but not health professionals. There are among us people who are health professionals, and also I guess some people who work as psychologists, psychiatrists, psychotherapists. And I think to know who you are, it will help us to adjust what we will say. So among us, who are those who work as psychologists, psychiatrists, or psychotherapists? Okay. So thank you for joining us, and we will be happy to hear your comments and your input during question time. Who are those who work as health professionals? Okay, thank you. And who are those who are interested in health? Okay, thank you. So we will try to answer to the needs of all those groups. And as you see on the title, it is mental illness, emotions, and healing. This morning it was said that SDA approach was not disease-focused, but wellness-focused. Anyway, we will start with disease, and we will go to wellness. So I will start with mental illness, explaining what is the frame of work I use as my day-to-day activity as a psychiatrist. There are different models. I will share the one I use, and that helps me. And then we will discuss about what are the options for healing or not healing according to various diseases. And then Cesar will deal more about psychotherapy with a Christian perspective and the link, the blend between psychotherapy and spirituality. And there will be a break because we are here until 6:30, as you know. No, I don't think it will be until 6:30. We will stop a little bit before, and there will be a break so that you can drink and move a little bit. Okay, now let's start with this first part. So I wanted to share with you how we try to think, at least some of us, when we meet someone with emotional suffering. First question we will ask it is, what type of disorder, what type of disease, what type of illness? But we have also to ask ourselves two other things. What type of personality? What style of personality? And also substance abuse. And we will go more and you will understand what I mean with this. Okay, type of disorders. First, is it a psychotic disorder? Schizophrenia, persistent delusion, acute or transient psychotic disorder. Schizophrenia and persistent delusion are what we call chronic disease usually. At least it lasts for a few years. And with hallucination, people will hear voices saying, you have to kill yourself, or the police is knowing what you're doing. Delusions would be as if someone would think that in the hotel, in all of our rooms, there are some cameras and that are filmed and sent to the government in Prague. Okay, this could be some kind of delusion. Acute and transient psychotic disorder, it can be a person under stress that would change and have some kind of psychotic symptoms with delusions or hallucination. We will ask us, is it more a mood disorder? This we know. We know what is depression. And I'm sure you've met also some person with bipolar disorder. So an alternance of depression, normal mood, and mania, which means euphoria. The person feels great and think that they can do many things, that they can change the world. Another question that we would ask, is it more an anxiety disorder? Panic attack? In an attack, the person will think she's going to die or to faint or to choke. Phobia in the elevator, phobia with araignée or all kinds of animals. Obsession and compulsion, you know those kind of people who need to wash their hands maybe 30 times a day, who would spend hours ordering their space, their room, who would spend hours cleaning, or is it a post-traumatic stress? Okay, this is a first question that we will have to ask. Maybe I give an example. 2 weeks ago, in the hospital where I work, we received a lady. Her name was Claudia, and she's a nurse. She's a very dedicated nurse. She's a very dedicated Christian lady. And 1 year ago, as she was praying, a thought came to her mind. You must go in a monastery. You must go in an isolated religious community, and a very strict one, where it's difficult to go out, where you have very little contact with outside. And this kind of thought became to come in her mind, and again, and even when she was taking her Bible, and she was reading, this is the path I have for you, for your life, right away, the idea was jump in her mind, okay, the path God wants me to follow is to go in that monastery to be a nun. She had hard time to sleep. She would stop eating, and she couldn't do her work properly. And so she went to see a physician, And she was put on neuroleptics. It was diagnosed as a psychotic disorder. Why? Because she had had that in the past. And when she went as a missionary to work with the stress of the mission field, she would have this kind of ideation and thinking. But the neuroleptics didn't really help. It only calmed her down, but the thinking continued. So at one point she had to come to hospital, and she decided to come to our clinic because she knew that there was this Christian approach that could be offered. And when she came, she was really under anxiety, really tired, and she was ruminating always. This kind of thinking was there. And it was even not very helpful for her that we could do a real psychotherapy, because right away there will be this thinking coming. And so we followed with what has been diagnosed before. Okay, it's some kind of psychotic thinking. And we put a sedative neuroleptics at a slow dose. This was like 2 weeks ago. And it helped her to rest and to sleep. But the ideation was still there. So we were there. I'm sure she was praying about the treatment in our clinic. And of course, as you do when you are with patients, I'm sure you pray in your heart. And God, I think, told me, but maybe it's another problem. Maybe it is not a psychotic thinking. Maybe it's more an obsessive thinking. And you see, it's a complete change of frame. It's a complete change of treatment. And I shared that with her. It's an hypothesis. We'll see. But maybe we could look at this. One of the problems was maybe God wants me to go to that monastery. Maybe God wants me to obey him. And as long as I am not going to obey him, I will not have peace. You know, we have all had this kind of thinking in our life. And I said to her, okay, maybe it's an obsessive thought that you try to push, and the more you try to push it, the more it comes. You know this. You know, a classic example is, please don't think about a white bear on the pole. I'm sure you can now all visualize a white bear, but please don't think about a white bear. And the more you will try not to think about a white bear, you will think about it. Okay, but for her it was not a white bear, it was I should go, and God is calling me to go in that monastery. And what really helped her, and last week she told me it has been the key, it is when I told her, if it is an obsessive thinking, there is no risk that you might do it really, contrary to your will. And to realize that this thinking could not force her, the tension subsided right away. And then I printed an article explaining and showing that there was no risk for her, that she could do this according to her will. Later on, she really looked at this thinking. Is it really God who is forcing me, who is saying to me, if you don't do that, you will not have peace? And she realized that in her life with God, God had never forced her in that way. All the decisions she had made in the past, and she had really committed her life to God, all the decisions had been made in peace. And when she would take decision with God, it would be in peace. And so she got the conviction that, in fact, it was not God who was asking her to do that. Okay, so this is just an example to show that in our frame of work, we really need to say, okay, in which type of diagnosis are we? Another issue that we have to ask is there a personality disorder? And personality is the style that we are. Okay, there are all types of personality disorders. It can be emotionally unstable. It can be histrionic, meaning someone who needs attention that will show, and so everyone will see that that person is here because she needs attention. Obsessional, things needs to be done very well. Dependent, or paranoid. Last thing that we will ask us, is there also substance abuse? And so the list is long. I put alcohol, cannabis, tranquilizers, we could put sleeping pills, and many others. Let me take an analogy with the house. The disease is what is the problem in the house? Is it the roof, which is leaking? Is there an electrical short circuit? Plumbing problems? Any kind of problems that you can have in a house. Okay, this is the disease. Personality is the style. Is it a Mediterranean house, Russian house, a Swiss chalet, an American type house, whatever? This is personality. All kinds of these houses are good. It depends where they are. I take an example. If I want to have a Mediterranean house, I live in Portugal, that's fine. This house will suit well. But if I decide to move, and I need to move to Siberia, and I say in Siberia, I want still to have a Mediterranean house, then there will be a problem. And this is what we have with personality disorder. It's where we are all different. Cesar will explain how childhood will have an impact on our lives, and usually personality comes partly from the events of our childhood. When is it a disease? When it is a disorder? It is when it is really fixed, when we cannot adapt our personality. Let's take an example, paranoid. If we would have a walk together in New York, in some suburb of New York, I think it would be a good thing to be watching what's around us and think, okay, let's look. This would be adequate. But if we would walk in the forest and we would always look around us, then it would be inadequate. And so this is what is a personality disorder. When we cannot adapt our personality adequately to the situation. Now, I go back to the house. Substance abuse, I would say it's like paint. Let's say there is an electrical short circuit. I go to the electrical box and I see it is black. There has been a fuse blown out, maybe a little fire, and it is black. I say, oh, it doesn't look nice. I will paint and put some white paint on the black in the electric box. And after it looks nice, I feel better, but of course the electric, it is not working. And this is what is looked with a substance, to feel better for a while. And at one point, we are so frustrated that we decide to throw the whole bucket of paint in the electric box. And what do we have? We have two problems now. The electricity is not working, and it's the mess. It's all leaking. And this is what happened with substance abuse. At the beginning, there is one psychological problem. We add substance abuse, and then we have two problems to deal with, two separate problems. So this is the frame that I try to approach my patient as a psychiatrist. Let me give an example about how this is going to impact with the problem of healing with psychiatric disease. Deborah, I will go back to this, and I'm going to tell her story. Deborah was born in Italy, in Roma. She was the third of 4 sisters. Her parents were very talented people. The mother was an artist, and the father was a filmmaker. He was making films for TV. There was a problem in the family. The father had schizophrenia, and a lot of attention of the mother was absorbed by the problem of the father. The little Deborah was there. She was the third one. There was another smaller sister, and so she didn't have much attention. And there was so much pressure on the mother that she decided to put the 3 oldest daughter, Deborah, was part of them, in a boarding school. I think she was 6 or 7 when she was sent to a boarding school. And so she had to adjust. She had to be with other children, with older children. She became a teenager, and she was doing some tricks. And as a teenager, at one point, she decided she wanted to have her life and travel and not come back as often as the parents wanted. And then the parents told her, well, if you don't come back, it is not necessary that you try to come back again. And she did it. She didn't come back. And when she tried to come back home, they told her, no, you cannot come home now. And so she continued her life. She had many boyfriends. She had all kinds of activities. She went in different countries. She went in Brazil. She went in Switzerland, in Italy. And finally, she settled near Geneva. And sometimes she was very depressed. Sometimes she had some brilliant ideas, all kinds of energy. And she started to use all kinds of substances, alcohol, cocaine, heroin. And at one point, she decided it was the mess in her life. She was going to jump from a bridge. And she went to a very high bridge in Geneva. And when she was ready to jump from the bridge, she said, oh, there is one thing I haven't tried yet. It is God. And so she didn't jump. She looked for a pastor. She found a pastor, and she has started her walk with God. And she has started to pray, please, God, heal me. And my question is, what would you guess will be the answer of God? For Deborah, answering the question, what's wrong with me? She would say, okay, I take cocaine, I take alcohol, it is not good for me, and I feel bad. I have anxiety, it's a mess in my life. This is all what she could say. But maybe with your training, you can say more. What kind of, okay, substance abuse, this we know. What kind of personality disorder do you think she may have? People? Bipolar, yes. She has a bipolar disorder, thank you. And as a personality, she dependent, she felt abandoned by her parents, so a need of attention, and she was bipolar. Okay, so the prayer was there. Please, God, heal me. She couldn't say, I have bipolar disorder, I have a dependent personality, and I am abusing substances. So what happened? And you know, this is the question we may ask. Where do you see the highest potential for healing? We will discuss more later on about the different type of healing. But you know, among all these situations, where do you see healing possible? Where do you see that healing is difficult from your experience? Okay, in the case of Deborah, what part do you think was the less difficult to heal? You say substance abuse, you're right. At least in her case, huh? She prayed, and right on the spot, she could stop using cocaine and alcohol. Okay, so among the three problems she had, one is over. Well, it's over not completely. Why? Because there are some scars, some sequelae of the substance abuse. You know that cocaine users, they feel so much pleasure. It's so high to take cocaine that for her, normal life is not so pleasant. It's gray, it's boring. And you know that someone with manic episode, it's so much high to have a manic episode that normal life is really boring for her. Anyway, she is not now this, it's nearly 20 years now that she has made that prayer. She has not taken again cocaine or alcohol. And I am personally convinced that any substance abuser can be healed. At least this is my conviction. Maybe I'm wrong. Maybe there's some very difficult case. I don't know. 3 weeks ago, we received a man with alcohol dependency. He told us, I've been forced by my wife to come. Okay, this is not a very good start, as you know. But I told him, I believe you can be healed, you can be better, if you use all the means, all the treatment. And the first 3 days, he wasn't very helping. Unfortunately, or fortunately for him, he had epileptic seizures in the withdrawal, even if he was taking some medication, and he was so afraid and so afraid with these seizures, he said, oh, okay, this is really serious what I have. And after the seizures, he was ready to change and to enter a motivational trip. And we could really discuss. And he has left 2 days ago, our hospital. And he had made a trip. He was not yet cured, as you know. 3 weeks or 2 weeks without a substance is not, of course, that you are cured. But it's the beginning of a motivational path. Okay, we go back to Deborah. What happened to her when she gave her life to God, asking for healing for her problem? 6 months later, she was admitted to a psychiatric hospital, first time. And 6 months later again, second time. And in the row, she had, I think, 4 or 6 hospitalization in the public hospital, psychiatric hospital in Geneva. I believe it's an answer to her prayer. Why? Because it gave her the opportunity to know her disease, to know how to cope with the disease, how to live with the disease, and maybe there could be also some treatment that could help her. Now it's 10 years that she has been on the treatment, that she has tried to change it sometimes, but she had maybe once in 10 years the necessity to go to the hospital. And as you know, people with bipolar disorder, sometimes it's several times a year that they have to go, and they lose their job, and they lose sometimes family, and they lose their money, and so on. So in my understanding, and you'll see that it is not her understanding, in my understanding, she had been answered to the prayer of her healing because a diagnosis was made and a helpful treatment could be given to her. Now, when we discuss with Deborah today, okay, she's happy to be with God. She's happy not to take substance. She takes her medication regularly. She knows that as a Christian, if she goes to some charismatic circle, is going to change her way of thinking, and she will go into a manic episode. So she tried to avoid them, even if she's very attracted by them. She knows that she has to sleep regularly. But she says, I don't feel well. And people, they don't care of me. And when I can be in a church and sing loud and talk loud, I like this. And when the people are a little bit afraid and say, oh, okay, this lady, she's a little bit out of the way, well, she smiles in herself. Why? Because now she has to deal with a third problem, which is the hardest to deal with, personality. She feels still abandoned by her parents. And she has a hard time to relate to God as a father. When she thinks of her father, it is a monster of the psychiatric disease. And this is the way she relates to the image of a father. And so she's been, over the past 3 years, to some workshops, some weekends, about relating to the Father, the Heavenly Father, the earthly Father. And she's doing a work on this. But there is still a way to go. She feels abandoned by her family, and so she tried to get in contact with them, but they're a little bit afraid of her because of her disease and because of her need of attention, which makes the people free from her. Okay, so you see that healing is possible, but we have to see with, according to the problems, what is possible with healing. Now, what would be an appropriate goal? Healing, stabilization, recovery, miraculous healing. And I think this is very important with our patients, important with people suffering, because if the goal is not appropriate, there is a lot of frustration. Let's just go back to the meaning, and then we'll go back to the question. Alors, the meaning, healing. Okay, this morning we've discussed about healing, to restore to health, to cure, and you know that in the book Ministry of Healing there is a whole chapter, the 18th chapter, which is called Mind Cure, to set right, to repair. Of course, this is what we all want for our patients, and this is what they want. Now, stabilization, to make stable or steadfast, to keep from fluctuating, and we hope it doesn't go too much downside. Okay, maybe this is to be a little bit not optimistic to have this kind of view. And then there is a third concept that emerged. It is recovery. Recovery is a journey of healing and transformation, enabling a person with mental health problem to live a meaningful life with the limitation of the illness, in a community of his or her choice, while striving to achieve his or her full potential. It is not healing, it is learning to live with one's vulnerabilities. You know that in the past, the psychiatric patients, they were way in the woods. And if you go in cities and you look for the psychiatric hospital, it's outside, in the country. Now it's not anymore in the country because usually the city has been around the psychiatric hospital. But 100 years ago, all the psychiatric hospitals were away. And you know that around, 30 years ago, 40 years ago, it has been decided to put back the psychiatric patients in the city, among the community. And this is with this kind of approach, recovery. How to help someone with limitation live with the full potential. An example, this is the website of the Substance Abuse and Mental Health Service Administration, so the health department of the United States. And look at the top, in the middle, what are their motto? Behavioral health is essential to health. Prevention works. People recover. Treatment is effective. And if you type in Google recovery, or even on this site, you find all kinds of materials about recovery. And there are all kinds of studies, too, about recovery. Let's take an example, evaluation of a recovery-oriented training program. There has been some sessions with health professionals to change their mind. Because when we see a patient on the path of recovery, we will treat them differently. Now, what would be an appropriate goal? And for Deborah, what was her goal? Deborah is in a church where they really believe in miraculous healing. And so it's very difficult for her to hear something else. She has been to meetings. She prays about it. She has seen pastors and pastors. And when I mentioned to her, well, maybe, God wants something else. It's a lot of frustration. She's very angry, and she cannot accept it. In her same church, I follow another patient who is the member of the same church. And he also has a bipolar disorder. He was really depressed about 2 years ago or 3 years ago. He was suicidal every day. Finally, after 3 months, he went out of the hospital. And gradually, we worked together. Gradually, he could work, 10%, then 20% he could work, and then 30%. And then after 6 months, he was working 100%. But he was really, really depressed. Okay, we continued with that. People around him were saying, well, you have to pray, you must have faith, and you will be cured. He was really angry with that, knowing that it was not working with him. And finally, he has decided to really learn about his disease. He has learned that he had the responsibility to take time to rest. He's working for a company which sells goods for the farmers. So he worked the whole day. And when he was going home, he would find his family with 4 kids and his wife, which is very active. And so he would have to clean the dishes and to help for the children until 11 at night or midnight. And again, he was going again in the morning. And so he decided, no, I will stop that. I know the disease that I have. I will adjust my lifestyle. And I will even have to face my wife, who was not happy with that. I saw them together, and I said, I think there is a problem in your couple. The wife was very mad at me, and she didn't come back, and I didn't offer that she comes back with her husband neither, and we continued the work. Now for January, thank you. Now since January 12, he has been with a good mood. He's taking a medication, which is we have to try to keep as low as possible. He's accepting his disease. He is living according to the disease. After his job, he takes the bicycle, he rides. He has stopped some activities with the sport club. He has decided to go once a week to see a good friend and spend time with him, which was something new. Before it was not allowed. He had to work at home and spend time with the children. So he is, I think, in the way of recovery. And I think he feels in very good shape. And the good news is after 6 months, since 6 months, okay, the couple is working, and for Easter they went to a specific session, and after Easter he sent a mail, yes, this is great, now we can discuss together. So this was a very good news. Some question about miraculous healing. Is it faith or presumption? You know all about this discussion, what is the difference between faith and presumption, so I'm not going to address this. Acceptance of a situation, is it lack of faith? And a hard one, are there written promises in the Bible about mental health? What would you say? Yes. What is promised about mental health in the Bible that can say to any of our patients, yes, sure, this you will have? Huh? I give to you my peace. Okay, peace. There are many promises about peace. Yes.
You will keep him in perfect peace. His mind is stayed on it.
You will keep me in perfect peace.
Your mind is stayed on it.
If your mind stay on the Lord. Okay. Okay. So this we have promise of peace. Yes. Do we have promise that we will be always joyful? That always we will feel joy in our hearts? Not really. We have to go for joy, to have a joyful attitude, but it is not the same process. Huh? And so I think, okay, it is not possible to say, okay, this is a line between this is always promised and this is not. I believe that there is in Bible promises that God wants us to have bodies in good condition and will answer us if about substance abuse. I don't see how God could not answer that prayer. But maybe we can discuss that in a little while. Now, just to remember what is in that chapter, Mind Cure, in the book Ministry of Healing of Ellen G. White. These are all the title, the subtitle of the chapter. You know them. First one is control of mind over mind. What are the danger of psychotherapy? Okay, the problem is that we are both psychotherapists, and quite a few among you are psychotherapists. So this we will discuss, and I think you will have the answers with Cesar. You know that when she speaks of control of mind over mind, and when she speaks about psychotherapy, it's because of that, control of mind over mind. And I think as therapist, the first goal is not to have control, but to sit close to the patient, sometimes not to counsel the patient neither, sometimes to confront the patient, yes. Confronting meanings, what do you think of this kind of attitude? What do you think of this kind of way of thinking? This is confrontation. Or maybe to give some hypothesis. I often say to my patient, you know, yes, psychiatrists sometimes they go out of the way, they are known for that, but maybe I have this idea. What do you think about this idea? And it is them who can decide, okay, this hypothesis apply to me or not to me. Another subtitle in the chapter is sympathy. Bible principles of cure, healing promises, sing praises. And I invite you to go back to this chapter for this topic. Okay, now I would like to continue about the topic of healing and to compare with unipolar depression and bipolar disorder. These are among the most common psychiatric disorders. What do they have in common? How do they differ? You know what is unipolar depression, not disorder, sorry. unipolar depression. Okay, the mood is lowered, reduction of energy, decrease in activities, no enjoyment, no interest, concentration is reduced, no sleep, or sleep is disturbed. You know this. I don't need to go back to that. I recall some figures. 60% have suicidal ideations, and 15% attempt suicide in case of severe depression. And as you know, the best prevention is to talk about it, to ask, do you have ideas about death? Ideas about, usually I start with this, do you think about death? And then I want really to be precise, and do you think about committing suicide? And usually people, they are afraid of saying, and when they see they can talk about it, they feel really happy, not happy, but relieved, thank you, to know that they can talk about this. And so I think you don't need to be a psychiatrist to talk about that. It's a question that can be asked by anyone, and it is the best prevention. As you know, the sex ratio for unipolar depression, yes, it's not disorder, it's depression, is 2 women for 1 man. The lifetime prevalence, meaning the risk of having the disease during one's life, is 20% for women, 10% for men. Precipitating factors like a disease, like unemployment, all kinds of divorce, in 25% of cases. For the first episode, usually it's more. There is a life event, a depression, but for a second or a third episode, usually there are not always life events. And usually it's only the souvenir, the remembrance of the emotions that comes back, and then you don't feel well, up you go back to depression. Mean age 40 years, and genetic disposition. For the first degree relatives, it's 10 to 20%. So if someone has depression, the risk of the brothers, sisters, and children is 10 to 20%. As you see, it's the same as the lifetime prevalence. For the twins, you know that these studies with twins gives very important results. So the false twins are the dizygotic twins. So they share, like brothers and sisters, half of the genes. The monozygotic twins are the true twins. They have 100% of the genes. And we see that if one twin has unipolar depression, there is a 50% risk of having depression. So there is a genetic predisposition that can be found. The factors for depression, okay, genetics, life event, a few medication, like interferon is something that we use for the immune system and to go against some virus, like hepatitis C. Mefloquine is what is used for malaria. Okay, we know that this medication and many others can lead to depression. The lack of thyroid hormone can lead to depression, some somatic disease, like we know of that pancreatic cancer is the first time sometimes is depression, and then we find the pancreatic cancer, Parkinson, social environment, and the dysfunctional thinking. So there is a lot to say with dysfunctional thinking. I believe Cesar maybe may speak about this. With psychotherapy, it is dealt mainly with cognitive psychotherapy. How do we think? I must do that. I must please everyone. And life must be perfect. And I must be good all the time. And so on and so on. All those kind of dysfunctional thinking. Now, the treatments. The treatments and what we use first with medication. you know that are antidepressant. They act on serotonin or noradrenaline, on both. When someone take an antidepressant, 1/3 of the patient, they go better because of placebo effect. Placebo effect is effective. It helps 1/3 of the patient. 1/3 of the patient, they go better, they get better because of the medication. And 1/3 of the patient, they don't get better with that medication. It is called resistant depression. And so we have to use another antidepressant or to use a combination of medication, just to show the impact of medication on depression. It's a help. It is not like antibiotics for pneumonia. It's a help, but it is not the panacea that will cure completely the depression. Herb treatment. Hypericum perforatum, I use the Latin name so that you all know what is the plant. Maybe not. In French, it's millepertuis. In English, it's St. John's wort. And I think in German, it's also St. John something. Okay, so this is a plant that is used for mild to moderate depression. But you have to know that that plant is not a natural treatment with no side effect. If you take other medication, there is some interaction. And so it's important not to take it without knowing the effect of that medication on the other medication. If you go in the sun, you can be burned. So you have to be careful. Exercise, okay, we all know it is good. And we can really prove with good studies that exercise is just as effective as medication for moderate depression. So exercise is very important. Sunshine, you know also that it is important. You know that we use it for seasonal disorder, depression, the winter depression. So sunshine is important. Social network, appropriate thinking, trust in divine power. So, can we say that depression can be healed? I think we can say yes. There is, however, a problem with depression. It is the following. The risk of relapse. After one episode, there is a 50% risk of relapse. If you've had 2 episodes of depression, 70% risk. 3 episodes, 90% risk of relapse. And so now a lot of work is done about how to lower the risk of relapse. Okay, some physicians, they say, okay, now you have to take medication all your life. After 2 episodes of depression, you take antidepressant all your life. I believe more in the other options. Psychotherapy. I think if you can really adjust your thinking, if you can really adjust some of your dysfunctional thinking, you diminish the risk of relapse. Meditation and mindfulness. You know, it's something that is really up to date, fashionable to talk about mindfulness. Mindfulness was taken from meditation and Eastern meditation. It's the self-regulation of attention so that it is maintained on immediate experience, allowing for increased recognition of mental event, is to accept, to notice what it is now. If we would do mindfulness right now, we would stop talking together, we would just sit on our chair, maybe close our eyes, and feel the chair, how it is on our back, and so on. So just to, and it is important, particularly with experience, to accept the experience with acceptance, openness, and curiosity. Okay, this comes from meditation. Is it opposed to Christian meditation. What do you think? What is your experience with that? Okay, so we believe that help comes from God. Huh? Yes, we do believe that.
I think that the concept of meditation is, in our minds, Adventist mind, too, like it's secular, we don't get it. But the Bible talks about meditation. Some said that we should meditate in God day and night and look at ourselves.
I'm going to tell what you said so that they hear, and maybe on the television too. So this is also something interesting. In our church, we say meditation is secular. We don't need to use it, but the Bible talks about meditation. And so there is an invitation for meditation. I think we have a treasure as Christians with that, because it will be accepting openness, curiosity, but not centered on us, but centered on a relationship. And this makes it so much more interesting. One of my colleagues, she said, I think 2 weeks ago, yes, every day I spent 1 hour meditating. She's not a Christian. And so I think it's this kind of mindfulness. And I said, oh, my poor lady, it must be really boring. We can spend 1 hour with our God, and it's so much more interesting, I believe. I don't want to judge people who do that. I think it helps them. And there has been some studies, like in Geneva hospital with a PET scan, where they take pictures of the brain, doing activities, and they have seen that in case of stress, there are some areas of the brain that will light up, that will get red in the pictures. And when they have trained with mindfulness and meditation, and even more, I think, Christian meditation, then the way the brain reacts to stress changes. And so there is really an effect that can be viewed with meditation. So I really believe we have good way of healing depression, good way of preventing relapse. And as you know, there are books with that. You know Dr. Nidley's book, I guess. There are seminars with that. Now, bipolar disorder, as we said, there are sometimes with a very low mood and ideas of suicide, and sometimes with the mood is really high. The lady Deborah I was talking about, one day she was high, and she said, yes, I have a bright idea. I am going to invent the day of hello. So we will advertise, today it's the day for hello, to say hello, and so you will say hello to everyone. A bright idea of someone who is in a manic episode. Or when she is in a manic episode, she wants to give gifts. And so she's going to spend hundreds of euros or Swiss francs to give gifts, and so on. But when she feels great, when she feels like this. But after she gets depressed because she sees the consequences. So, first, approximately 30% of what is called unipolar depression, in fact, is a bipolar disorder. So there is a misdiagnosis, and so this we have to be careful because it's a different approach. It's the same sex ratio between men and women. Fortunately, lifetime prevalence is lower. There is a risk of 1% to have the disease during one's life. Mean age is 30. And for me, what is interesting is to see, and important is to see about the genetic predisposition. If for twins, false twins, if one has a bipolar disorder, there is a 30% risk of having a bipolar disorder for the other twin. For true twins, 70% risk. If you have one parent who is bipolar, you have a 25% risk, 60% risk if you have two bipolar parents. So, in my understanding, I think it is one of the most biological psychiatric disease, where there is this genetic part, fortunately not the only part, and we'll discuss later about also the life event and what can be done with them. Okay, genetics, irregular rhythm in life, lack of sleep, stress and stimulating events, substance abuse, and cannabis will really facilitate some kind of crisis. Treatment, okay, the medication. I believe that someone who has a manic episode, I don't know how you could help that person without some medication. You know, if you really want to do something, okay. Yes, I was said that in the lifestyle center, someone was in a manic episode. It was decided not to give medication, so it was walks and maybe hydrotherapy treatment. But I think in most cases, the people around that person will be tired much before that person will be tired and will go down. So I think in some case, in a manic episode, you need to give either a mood stabilizer like lithium or valproate, sometimes neuroleptics. But it is not all about bipolar disorder. We know that a regular life, I expressed the example of that man who has a regular life. He has his job. After his job, he takes the bicycle, and then he rests in the morning. And when he wakes up at 6:30 in the morning, he's a Christian. He reads the Bible. He tries to have a regular life, and this is important for bipolar disorder. Psychoeducation of the patient, of the family, is very important too, because when you understand better, you can more monitor the disease. There are a few studies about the use of omega-3 fatty acids. You know, those fatty acids, essential fatty acids that you can find in some grains, in flax, or other kinds of grains, nuts. And that will really, so this can help. I don't think that we can say we can cure a bipolar disorder with that. Okay, now I will finish with these slides, and then we can have some exchange, and then we'll have a break. You must be tired, and I saw that some really fight to open their eyes. But I see that most of them you're fighting, so it gives me some courage. We have talked about mood disorder. For anxiety disorders, we don't have the time to go in details, but I believe it is an area where cognitive and behavior and cognitive therapy works the best. You know, let's see, yes, a patient, she is still in the hospital now, but she's been for months in the hospitals, afraid of being home. She has a generalized anxiety, panic attacks, and so she's unable to be at home, unable to cook, unable to drive. And so we had to start a behavior and cognitive treatment. And we made by steps. So she wanted to have all the time someone with her, to go even in the park, in La Linière. She wanted to have someone with her. And so, and the question is, please take away my anxiety and I will be in good shape. And you know that it doesn't work like this. And I told her, well, the way I treat anxiety is with anxiety. And she didn't like to hear that, but that's the way it works. We treat a big amount of anxiety with a little amount of anxiety, step by step. And I said, okay, let's see what could give you some anxiety, but not too high. And so she thought, and she said, oh, maybe if I could walk along the road by myself. And so I said, okay, and so you see yourself along the road walking by yourself? How is the anxiety? And so she tried to listen to her anxiety, to monitor it, and she said, okay, it's 5 to 6 above on 10 scale. And so she went, and as usual, as you know, anxiety is usually before, but not during the task. And so before going to walk by herself, anxiety was maybe 5, 6, and when she was waking, it went down to 2 on 10 scale, and when she came back, it was 0. And so we went like this, bit by bit, and then she took a bus by herself, then she went by herself in her house, and so on last week she was saying, please continue my stay in the hospital. I want to stay. I said, okay, there is one condition. I will ask the health insurance to lengthen the stay if you go every other night at home. Oh, it was tough for her. But she went, and she had the task of taking the car. And so, okay, just to give an example, how with this anxiety disorder, if we work with this approach, with changing our experience, there can be a lot of progress, and I think healing. Psychotic disorders. Of course, I don't have the magic way to cure this. Some hopes, anyway. There are some team who have worked with schizophrenic patients, and they have looked for allergies to gluten, celiac disease. And we know that for some patients, not all patients, I'm not saying that schizophrenia is due to allergy to gluten. You understand gluten, and the protein in wheat. But for some people, it works. I had a patient who had constant hallucination. And she had this hallucination for 3 years. And maybe once a week, she would call her and tell me, Doctor, I have this voice telling that I have to kill myself, that the police is following me, and that the doctor knows everything about it. And I said, well, I don't believe what the voice is saying, and you may believe me or not, but I don't know anything about it. I think it's your brain which is producing that. And so for months, every week I had to repeat again. And she was calling, and I was a little bit irritated at some time to repeat always the same thing. And one day, she came, it was 6 months ago, and she said, okay, I don't have any voice. Because she has started to have like a cognitive treatment with the voice, saying, okay, now, the voice here is here, but I don't believe it, I don't take attention to it, and she has seen an extension of the voice of the hallucination. I don't say that she is healed. Maybe next month she will be in my office again. But it has lasted for a few months. Personality disorders, I think it's the hardest. One of the hardest. In a way, it is nice, because there are no treatment that will change our personality. There are no psychotherapies that will change our personality. And I think it is nice. But we need to make our personality more adaptable. And I think the model for personality is Jesus. He had the most balanced personality. Usually the personality disorders are when you go on one side or one or the other in extreme directions. And Jesus knew how to be gentle, how to be firm, how to be loving, how to be confronting. He had such a balanced personality. So I think, yes, one of the best cure for personality is to go and to meditate on Jesus.